Good evening, everybody. Welcome to another episode of Mondays with Maishi. This is Maishi Norman in Lakewood, New Jersey. It's now just after 9 o'clock on November 4th, 2024. And it's nice to see everybody back. And tonight we have a return guest. Matis is his second or third time. I think it's third, at least, right? Third time. So third time in 4.5 years. That's a pretty good record. Matis Miller, who's a licensed clinical social worker in Lakewood, New Jersey, and the clinical director of InReach Behavioral, which is an IOP, which I don't know just yet what that means or what that even stands for. But the objective of tonight's discussion is to learn what is an IOP, as well as some of the numerous other levels of care that exist out there. And some of us, even clinical social workers, including myself, have not been privy to work in that many settings beyond outpatient. I mean, many of us have done our internships. My internship, 1 year was in an outpatient setting, 1 year was in a nursing home. So I learned a little bit about inpatient from the nursing home because a lot of the residents in the nursing home, were being fed from the hospital, whether it was psychiatric care or the physical medical hospital. But so I did learn a little bit about inpatient. But beyond that, things such as IOPs, PHPs, halfway houses, and many of these other names that we sort of nod when we hear, I was not ever necessarily privy to really understand both the ins and outs of what they are and what they do, as well as who would be the right candidates to refer there. And I think that's really predominantly what I struggle with. Sometimes client walks through our office and they just seem to be too much. And like I get the sense, okay, this person needs to be in therapy every day. This is not like a once a week or even twice a week client. They're in crisis. They have no control over their emotions. Ego strengths are very poor. They're just not functioning in some way, and I don't know where to send them. So I might have to reach out to somebody like Matis or somebody else and say, hey, where do I send this person? And I get a localized, customized answer for this particular client or patient. But tonight, I invited Matis to come on and tell us, a little bit about, can you describe the various levels of care, who they're appropriate for, who belongs in which level of care, who we should be referring where, and why we might be, quote unquote, unsuccessful or failing with some of the clients who come in who just seem way, way overwhelming for the clinician. So Matis, thank you for joining. And just tell us a little bit about how you fell into IOP and all that.
Okay, Maishi, thank you so much. And thank you for having me so many times. And it's a real pleasure to be here. And I already see some people in the audience. I recognize your names, so thank you for joining. So when we think about this topic, some people think it, like, as a therapist, this doesn't really relate to me. Like, as Maishi mentioned, like, I work in outpatient, I deal with outpatient, I don't need to understand these other levels of care. And it seems, there are so many topics. I know that I get Maishi's weekly emails and really exciting topics. And there's like, okay, understanding levels of care, like, why is this so important? And I think it is, as a mental health professional, to really do the best you can for your clients and understand what their needs are. I think this is more important than therapists realize. And often the way therapists learn this is if they have a client who ends up in such a state of crisis and is forced into different levels of care, as opposed to prevention or identifying when it can really be most helpful and useful for their clients. So in my about 20 years of practice, I actually worked in 3 levels of the 5 that we're going to talk about today through my career. It was interesting. I was speaking to one of the clinicians who work at InReach Behavioral Health, which is the IOP PHP program that I founded and direct clinically. And they mentioned to me when I was having this discussion, they said that when you told me about the IOP and working at IOP, I have to be honest, like, I ran to Google. I'm like, what's an IOP? Like, I know I'm supposed to know what an IOP is, but I have no idea what an IOP is. And I would find that like experienced therapists who've been practicing for a number of years, yeah, they've heard of intensive outpatient or maybe partial hospital or maybe residential, but they don't really understand it or know what it is. So I think some broad things that we keep in mind is most of these treatment levels are short-term care. When we think about the level of outpatient therapy, individual therapy, that could be long-term care, but primarily these are more intensive and more short-term levels of care. And I think the way we think about these level of care, if you think about all these five that we're going to discuss today, think about it as like a staircase about stepping up and stepping down. And there's a process that happens, for an individual through their trajectory of mental health care that they might be stepping up and down. And sometimes, unfortunately, numerous times we see that with the most complex clients. So the five levels that I'd like to talk about today is
Oh,
outpatient.
Matos, can we just pause for a second?
Yeah,
I'm curious because before tonight's show, I also put IOP into Google and it came up with as initial public offering, and I got all excited.
sure.
And then I realized that I wrote IPO instead of IOP. For
Yeah,
those of you who know are familiar with what an IPO is. Sorry, I had to throw that in.
yeah.
So, but I'm curious. We have right now 16 participants on the call. We're still early on, and I'm sure more will join. And the question that I'm wondering is, has anybody here worked or really done their internship or worked at something other than an outpatient? I shouldn't say other than an outpatient, but something that would be considered a higher level of care than an outpatient. If you could raise your hand or unmute, and of course we love when people's videos are on. So if you can turn on your video, that would be great. That applies to everybody. But I'm curious, how many of you have actually served in a higher level of care than an outpatient? Cecil, can you tell us, Yankee Cecil, would you unmute and tell us like what level
Yes,
of care was it, and would you
right.
say that the
I
exp
yeah, I got a client after being in an outpatient program, like weaning off of a higher level of care, but I wasn't actually working with that program or while the client was in program. And it was a constant struggle of like, does she still need it? Speaking with the supervisor, making sure that, everything is fine. And at the time, as we're speaking, I'm in a dilemma with a different client who might need high level of care. And yeah,
Okay.
So how would, I guess if I can ask you, how would you define, based on your experience, what would you understand an IOP is? You had a client who was coming from an IOP.
I mean, I would say that was the first year of my internship. I was clueless. I felt sorry for my client. I felt like she should have gotten a better therapist or a therapist that was longer in the line, but there wasn't any available. I was trying my best to service her. I can definitely say there were mistakes there because if I would have had more expertise, I would have been able to, provide more. But again, as therapists, like, we can only do what we can. And that's also the reason why I'm on the call now, because I want to make sure that not just my supervisor tells me what to do, but maybe there are other people that know a little bit better or can guide me a little bit more to make sure that I'm doing giving the right services to my clients.
Okay, that's great.
That's one.
Yankee, I noticed you raised your hand. Would you share what setting you worked in? Go ahead. Oh, you got to unmute though.
Yeah. So I finished my internship. I did it in a drug rehab. It was PHP and IOP.
Okay, and how did you find that experience compared to, again, I don't know if you've ever been an outpatient or if you've ever worked in an outpatient, but the way you might imagine an outpatient, which is fairly straight up, client comes to the office, does therapy, goes home, comes back the next time. How would you compare the PHP experience?
So I'm not I'm starting now in a outpatient. So I never really experienced it yet. But I'm saying it's pretty, at least PHP, it's pretty intense, and being there every single day eventually you start seeing a lot of change that probably you don't see. I would imagine you don't see that much change in the outpatients of once a week.
Mhm. Okay. All right. Is there anybody else who worked in a higher level of care or intern and would share the experience with us? Thank you, Yankee.
Hi, Moshe.
Hi, y'all.
So at training as an addiction professional, and so I did the CSAT training. So those trainings were each one was in an inpatient facility. So we didn't work with the clients directly, but we were ended up seeing multiple inpatient facilities, and we were given tours and explained how it works and the groups and whether they're how much they're trauma focused, and just to learn about what the schedule is. So that gave us a very good idea of some different inpatient facilities. And then I did do work before I trained as a therapist, as a chaplain. I did work in halfway house, and which I would say is an intensive outpatient. So you could see the difference where there's that freedom, and yet they're seeing therapists every day, and they have access to so much care, and they have a support system. And I know there's different levels of IOP. So that was, I guess, a higher level of IOP, but I would just say it's how much support, how much support, how much we've got you, and how much there's less of a chance you're going to fall. And then, and there's different levels of growth, obviously, when you can fall, you can grow.
Okay.
Yeah. So I would actually, I appreciate all that feedback. Actually, if I could jump in and sort of give an overview.
Yes, that's where we're going right now.
Care, and I think to give everyone some more clarity and understanding and ask some questions. So most of you are familiar or are currently working in some sort of outpatient. That can be in a clinic, that can be a private practice. And usually outpatient, there's individual therapy, there's family therapy. There might even, outpatient could even be going to see a psychiatrist, a nurse practitioner. In terms of therapy, when you talk about an outpatient, it's usually 1 to 2 sessions a week. A flag in your head is if your client needs more than 2 sessions a week, I think that's like, hey, maybe we should be thinking about a higher level of care. And that's something I experienced over my career. When I see they need so much support, that's like a flag that clearly, the need is valid. But if you're providing more than 2 sessions, and certainly 3 the most, then likely they're not getting the right support in that environment. So that's the outpatient care. I don't have to talk so much about that. Most of you do that. The next level.
Matt, I would add a caveat to that if it's okay. There are psychoanalysts who do provide more than that, but that's not necessarily. I think what you're saying is if the client can't manage with fewer than 2 or 3 sessions a week. Correct. I'm assuming that's what you mean.
Correct. Okay. That it's a need. It's a necessity. The next level of care is IOP, which is intensive outpatient. And it's a more structured and more frequent than regular outpatient. And generally a person, obviously, who's in IOP does not require a hospitalization or high level of care, which we'll talk about. Now, IOP is anywhere from 3 days to 5 days a week. And every day is 3 hours of therapy. Now, primarily, most of the work that is done in an intensive outpatient setting is a group setting. Most of the therapy is groups. Someone asked, they have 3 hours of individual therapy 3 times a week. That's a lot. Now, they do get individual therapy sessions. Sometimes they have 2 sessions a week. Sometimes there's family therapy, and there's a lot of collaboration with providers. But most often, they will be having group during that period of time. Some programs will have 3 groups, some will have 2 groups. Now, who decides? This was a question I had when I went into higher levels of care and I started the process of structuring the program. Who decides it should be 3 hours? Where's the research on this? Why? Maybe it should be 4, maybe it should be 2, maybe it should be 1. Why that amount? And the answer, I don't really have a great answer to that question. What I can tell you is a lot of it is defined by managed care, right? So insurance companies are defining what is called partial care, intensive outpatient care, partial hospital, somewhat licensure as well, right? So the licensure in the state. So I have an IOP PHP program and I'm licensed in the state of New Jersey. So they are defining what is considered an IOP. So someone can be going to IOP for 5 days a week for 3 hours a day and getting an individual session on top of that. And that can be, quite intensive. And really it's, there are different types of IOP, as someone mentioned. Some of them are focusing more on emotional behavioral health, and some are focusing on SUDS and substance abuse disorders and co-occurring disorders. Some are focused on specialized OCD intensive outpatient programs, eating disorders intensive outpatient programs. So there are specialized IOP PHP programs, as we'll talk about, but that is the overall environment. So it's a very, very supportive environment. So they're there for 3 hours a day, and usually there are group facilitators, individual therapists, there's support staff, and there's an entire environment that they're on a daily basis. And we'll talk more specifically, but this is really for people with treatment-resistant depression, suicidal ideation, self-harm, emotion dysregulation, mood disorders, bipolar, psychotic disorders, personality disorders. People have significant trauma, complex grief. So it really gives the opportunity for people who have moderate to severe mental health issues that don't necessarily need complete daily support. Like they want to be with their families. Some of them could even be working part-time. So there are intensive outpatient programs that, like we have a mail track that we're developing for the evenings from 7 to 10 at night. So that can allow a person to go to work and then at the end of the day, focus more intensively on their mental health treatment. And so it's just more concentrated. At the same time, they can certainly be in an environment that doesn't need as much support. And it offers a lot more therapy. I mean, that's you're getting, and in a group environment as well. So there'll be lots of therapeutic modalities. You'll have, and a lot of different, which we'll talk about, types of group. And you can learn skills in a shorter period of time. It gives them a jump start to recovery, and it's a very supportive environment. When I did a lot of research in terms of intensive outpatient partial hospital programs, it's interesting. Like, what is the magic sauce? Like, what does this? Like, what makes this environment so special? And of course, certain specialty treatment, those things can certainly play a role. But a lot of it is that really supportive sense of community, that connection, that getting, a lot of people are struggling, we know, in our community and beyond. There's still a stigma of mental health. People feel alone. People suffer, shame. They don't feel very validated or understood in their environment. And they're among other people processing and learning and getting support from one another. Now, obviously that has its dangers and risks as well, which is quite complicated, which I could talk about even in our program, where we actually had to put in a very strong policy that they could not connect outside of group. I started at first where I allowed people to connect outside of program, but I realized that it was actually therapy interfering and creating problems. So on the one hand,
and what about group dynamics? I mean, I'm sure that's group dynamics are so complex, especially with people with personality disorders and whatnot, where they either dominate or withdraw, or avoidant personality, or not.
And I've been in outpatient, I've been facilitating groups for way over a decade, and there are different groups, different dynamics. Here they're with them every single day or 3 days a week for 3 hours a day. It's really complicated, and a lot of that comes, we're trying to use the environment to help them be skillful or address the whatever's prompting or triggering their emotions in the moment. So yeah, the dynamic, and we get different groups. Like I've seen it already. Like just recently I had, one of our team meetings, our therapists are like exhausted because there's such negative energy in the specific group, the cohort that we have right now, that it's making it so hard to be able to treat and address. So you're right, Maishi. I think the dynamics is a big piece.
So Mathis, just curious, in the IOP, you run InReach, which is a IOP in Lakewood and focuses on the Orthodox community. And I'm wondering about individual therapy. Where does that come into the whole IOP program?
So that's a great question. I really explain to clients from the onset. A lot of people have long history sometimes of complex trauma, specific trauma, childhood trauma. Some of them not, but some of them have, other struggles or social difficulties in their life or family dynamics. And they're coming to us, and the average stay, which I wanted to mention before, is, and we'll talk about the different levels of care, but in an IOP, usually people are there from anywhere like average, I would say 3 months. Okay, now they could be there longer or they could be there shorter, so they could be there 2 months. And people come with this idea, they're really struggling and they just want the magic, like, just come here and it's going to all be better. And it's something that are really, in terms of training the staff who are in the facility and also helping inform the clients, is that we're here to help you stabilize so that you can continue your treatment. And that's another thing, because a lot of outpatient therapists, they're like scared for, they don't want to lose their clients. I'm not saying because attachment issues, you could address that in another talk.
Right.
But
you mean just in general, clients doing well, they should be in continued treatment, and they don't want the client the treatment to be disrupted by something else.
Sure. And it's really, sometimes they actually want the disruption because they need a break, right? Talk about burnout. Like, therapists just need a break. It's a very difficult client. Like, take them for a few months and then I'll take them back. But our goal is really to collaborate with the outpatient therapists, because they have to step down, right? As we're talking, it's constantly stepping up and step down. And we want to make sure that's a huge part of this. Like, they're going to be with us for this period. We want to make sure that they have a discharge plan past us, because we know, and we'll talk about in terms of even hospitalization, the research, the follow-up care is so important. And that's why we know that there's an increased risk of suicide following discharge from hospitalization. And that's very important to know. Some people say because they're feeling just a little better with enough energy to kill themselves. But often because they just don't have the continued support. And we're seeing that actually in IOP, that when people, or PHP, when people start to step down, they had so much support where they left. So it's really important, that collaboration with the therapist. So we're giving them this message, and even in terms of the individual therapy, where we are a more evidence-based, structured program, and we have treatment plans, and it's goal-oriented, but our goals are really focusing on, the short term. Yes. Do we do some EMDR? Do we do some brief cognitive processing trauma work? Yes, we will do some of that work. And some of them will actually stay outpatient in our facility as well. So they'll continue with the therapist. But overall, we're really focused on helping them improve their functioning, their daily functioning, and their ability to regulate their internal process.
I think I wasn't so clear. My question, I had meant, is there individual therapy at the IOP?
Yes.
Okay. Was that clear?
Yes. So there's individual therapy aside for the group therapy.
How does that
Minimum 1 session a week, and sometimes 2, aside for going to the groups every day. So absolutely is individual therapy that's working. There's also phone coaching. So we also, to help them generalize the information that they're learning. It's very overwhelming. I mean, we're giving them a lot of information in a short period of time. We're not a fully DBT, dialectical behavioral therapy adherent program, but we actually are very, very DBT focused. So that means in our program, we have actually a skills group every day. They're filling out diary cards. Aside for other modalities, we do psychodrama, we do expressive art, we do yoga, we do dance, we do a lot of other modalities as well, which is one of the beauties as well of this environment too, is you're getting exposure to many modalities. It's a very holistic approach, which I think is helpful, because we see that some clients, as we know, some modalities they're more responsive to than others, or some need a different type of treatment. So that's in terms of the.
So how does it work with an individual therapist? Does that mean that as long as they're in the IOP, they work with their individual therapist, and then once they close out the IOP, they now have to stop that relationship?
Yeah, so we actually, in our program and other programs as well, is they do have an opportunity to step down to outpatient in the facility and continue, but that's not always an option. And sometimes people are not necessarily local. And that's where it's really important. You're right. The therapeutic, from your, the way you would view therapy in terms of building that relationship and that connection and that attachment and that understanding, you don't have much time to do that. Now, obviously, we have different ways of we discussed in terms of doing therapy, but all those components are essential, right? You have to, even in IOP, a PHP program, you need to develop some sort of trust and relationship with that client in order to do the work. But you're absolutely right. Like it is, and we're really preparing them on the onset. So
you're talking about termination from the onset.
Yeah, exactly. We're making they're from the moment they come in from an intake, we're explaining the program, how it works. We take 1 month at a time to see, is this a level that's appropriate? But let's jump to PHP.
Yeah, let's go to PHP. So I think we got the IOP pretty clear.
But I think
the overall idea is that it's for those who are struggling to function in daily life. They need more intensive therapy than once or twice a week, let's say twice a week, in order to function. There's a lot of both lower level and acute mental illness. And it's mostly, 4 or 5 days a week of 3 hour a day group therapy with, let's say 1 or 2 sessions interspersed of individual therapy.
Yeah. And IOP programs, like our IOP program, does not right now have medication management. Absolutely, many of the clients come already with a prescriber. We'll talk about that's one of the differences with PHP is you would certainly within, I believe it's 24 to 48 hours, you do have to have a psych eval. So you are providing that higher level of care. So partial hospital, actually in New Jersey, it's called adult partial care. I guess they don't want the hospital word in there. You don't want to make, if you go, contact the state and say, I'm working on my PHP license, they'll correct you really fast. Like, don't make that mistake. It's called adult partial care. Okay. So for those of you in New Jersey, so that's 5 days a week, 5 to 6 hours a day. So that's really intense. And they're there for a very significant period of time. Now they're having meals there. If it's adolescents, a lot of programs actually have schooling. They do schooling online in the program. So that's more intense. The average stay is less though. The average stay is, 2 to 6 weeks probably. So people are there. It's more intense, but it's shorter, and they'll step down to an IOP. I've found we're developing our PHP track now. We started with our IOP, that most clients on a 4 to 5 day IOP, it's sufficient unless, they're really coming out of an intense hospitalization or a significant episode or somewhere where they're really not stable and they need that stability. But there's another thing I realized too, is that a lot of people who are struggling and they're in bed all day, but they're not functioning and they're not doing anything, giving them a full day of structured mental health could be really helpful. There's a danger to that because when you discharge, what are you discharging them to? So that's another thing we really work on in a PHP. We really want to focus on structure and daily living and skills. And that's really, really important.
So let me ask you a question about this. If I I was thinking of different case studies or different individuals with whom I've worked who clearly needed something that's a higher level of care. How would I determine if they need a PHP or an IOP? Suppose you have somebody who's just completely not functioning. He's not doing anything with his life. He stays much of his day in bed, and even when he's out of bed, he can't commit to anything. He can't execute or complete anything. He's just completely not functioning. Would that be somebody who's appropriate for an IOP or for a PHP?
So I think I would leave that up to those who are running the program to assess, because I think every program is different. And hopefully you can trust the program you're sending. First of all, to see, they might not have both levels, but even if they have one, it's hard. This is an important piece to know also. I don't know if I should be saying this, but say it as it is. A lot of these substance abuse facilities, these IOPs, these PHPs, they are businesses.
Yes.
And you know,
They're going to want to maximize and get the most out of what they can get.
yeah. So when I obviously this is unique. I think I'm a clinician that developed and built and founded, and now I'm not saying there aren't other ones out there. And I'm learning as a clinician, I have to run it as a business because we're not great at business clinicians.
Correct.
So that's really important. That's important. It has to be run as business. But a lot of them are just going to stick them into PHP if they can get approval for PHP because there's more money in a PHP versus an IOP. The reason why I'm saying that, don't suspect people are doing that, but I think it's important to develop, you know, when you're sending or referring to a program, that you learn a program that is, you know, that you can trust, that there's positive, you know, feedback and on that program. What I would tell you is, it's really, again, if someone's just not doing anything all day and they're not functioning and they're not getting out of bed, but overall they're not high risk. We have people in our program that aren't high risk. You know, they're not currently suicidal, highly impulsive, engaging in severe. We have both. We have people can come after numerous attempts. You know, you have to have thick skin to work in this level of care. I mean, we have people who unfortunately are really in pain and struggling and very, very ill. And you have to be very comfortable with risk. But what I would tell you is that if we put them, we don't want to over therapize people, and we don't want to like just overdo it. So I think if someone's really not coming from a higher level of care, or they're just not coming from extreme episode, or they're not severely impaired in some significant way, I would lean towards IOP. But at the same time, you know, sometimes people need a jump start, and this is where PHP could be helpful. So even if the guy is not functioning, he might need that 2-week jump start. And that's what's nice about having a program as PHP and IOP, that they can step down pretty quick. You know, after 2 weeks, 3 weeks, you can transition them, and then you can build a life of structure and have them doing more things in their day and getting out there. So I think that's the value of.
So someone going into a PHP does not have to necessarily be coming out of a hospitalization or, you know, an inpatient treatment and stepping down into PHP. Somebody could come straight off the street into a PHP program if that's what's warranted, you know.
Yeah.
And I was, you know, I get the idea of being a business. Of course, they want to maximize what they can, and there isn't the line between being in a PHP and being in an IOP is probably very blurred. You know, as it is, it's hard to know exactly what somebody would benefit from, and why not put them in the best or highest level of care first, as a even as a protector. But I guess I was asking, you know, as a therapist who's referring to, I'm not the business. I don't care which one they go into from that angle. But if, you know, if I want to encourage a client of mine who's really, really struggling to go to one, would I tell them PHP, IOP? So that was the case example. Somebody who wasn't functioning at all in that way. But what if you have somebody who
I just want to, if I could just interrupt you there. There's also insurances here. Okay, so if a facility is taking insurance, you have to get approval for different levels of care. So you could say, oh, you should go to PHP, but they might not be able to go to a PHP program. Yeah.
Got it. Obviously. Okay. So now what if you have somebody who is sort of functioning? They're functioning okay, making ends meet, but very, very highly emotionally unstable. So emotionally dysregulated. I worked with an individual who was very, very highly depressed. He cried for most of the session. He cried for most of the time between sessions once a week. Was making me feel panicky. You know, trying to get him in more than once a week was difficult. He was coming from, you know, a drive away. And, you know, would this be an IOP patient, somebody who is just extremely depressed and needs a lot more support? Or would this be, you know, the degree of emotional dysregulation warrant a PHP? Or is it, again, subject to discretion?
Yeah, I think it's subject to discretion. And I think you want to send somewhere where people are familiar with this level of care so they can tease it out and assess. Right now, I don't know if I can always be doing this, but whoever's doing our biopsychosocial in our facility, I go into every single biopsychosocial for about 20 minutes to just do a brief assessment to make sure this is suitable, this is appropriate, this is where they belong. So I think that's a really important piece. I think I love your example because I think clients like that often don't get to an IOP for a variety of reasons. And I think that it can be super helpful for someone to really start, jumpstart their recovery for so many reasons. And there are so many benefits that they can gain.
Well, my therapist ego, is screaming, "Hey, we can help this guy. Let's do it." But my therapist intuition, or maybe my humane intuition, was saying, "This person is very, very is really, really in a lot of pain, and probably, after it's one thing if a person comes into session and is highly emotional, they're letting it out for the first time, exposing themselves for the first time. But when that continues week after week or twice a week for a number of weeks, and they still can't get a grip on themselves, that's reflective of something more acute."
Yeah. And of course, we have people come to our facility, and many of you've had patients that you've treated that they're stuck. And there are certain barriers in there. Perhaps they're not ready to get better. They're scared of getting better. Things like that. So we have an opportunity to really observe and watch and identify things that are interfering with their treatment because we're observing them and working with them significantly longer and more often. So that could be helpful. The next level of care is residential treatment. So the benefit of this IOP PHP, and I know you mentioned, Maishi, about Enreach, we're like in Lakewood, New Jersey, and a lot of the clients who come to us, their families, their life, their social life, their work life is all within distance. So they really can continue to participate in life. But sometimes there are individuals that they don't need hospitalization. They don't need that setting. But it's so chronic, so severe that they need a lot more support with medication management, with daily living skills, with therapy, with rehab, with detox. And that's where an average range of 30 to 90 days, where there are more of these eating disorders. And that was another thing, Moshe, that you mentioned before. Sometimes we're actually, hopefully within the next few weeks, we will be launching our eating disorder track, which I'm super excited about because there's a huge need in our community for that. And that has not been done as of yet. So that's really exciting. But someone like that, for example, they need a lot more support. They need meal supports, right? So we have to have meal supports, and they need to be there, many more hours. But many of them are stepping down from residential. So if someone goes to residential for eating disorder treatment, and they come right back to their environment, full of the triggers around them and the emotional struggles, they quickly relapse. And then where do they go? And that's where that intermediate step is so essential. Of having them step down from residential. So residential really is a bubble in a way, and it's really helping them, behaviorally and emotionally, and whatever struggles, whether that's, substance abuse, eating disorders, or, severe trauma and severe impairment. So they're moving to a facility, and then they have to reintegrate back to society. So that's where they read. So we actually had a team that we were treating. She was doing quite well. Severe depression, self-harm, and actually we tried to get them approved more, and then we didn't get approved, and they ended up, cutting themselves so badly, that they were really, it was medically quite dangerous. They ended up in the hospital. So at that point, there was a decision, not from our team per se, but after the hospitalization again, that she needs to go to residential. And they want to come back to us. That was very clear. She was doing well, but she needed more right now. Just the level of impairment and the level of support that she needed. And sometimes they just can't function. They can't be in school. So they need that higher level of residential care. And then there's the fifth level, which is hospitalization, inpatient care. So I don't know how many of you have seen.
Hold on. I'm not ready for that. I still want to go back to residential for a minute, but before I do, I want to just invite everybody who might have a question, either about a client that they're seeing, and if you do have a question about a particular client that you're seeing, I'm going to ask you to be really, really mindful and careful about how, what information you present, because this will be seen by hundreds or maybe thousands of people. So please don't present it or make it hypothetical or change so many details that it's impossible to identify. That's number one. You have a question about IOP, PHP, or residential, you can ask that now. I also did want to thank everybody, those of you who turned on your videos, and if anybody else can turn it on, you know by now that we love to see faces and have some real interaction. So thank you, Yosef and Cece. And I do want to just remind everybody that Mondays with Maishi is now sponsored by OKclarity.com, which is a great place to feature yourself. Thank you, Shoshana. Great place to feature yourself, your business, your practice, and any other engagements that you do, such as speaking, public speaking, psychoeducation. You could certainly reach out to OKclarity. They will host your website, do all the back-end work for you for just a few bucks a month. And it's really a nice way to get yourself exposure without having to do all the work of putting it together. We're also sponsored now by OfficeStreamline.com. Office Streamline is a virtual secretary service so that you can spend the hours of your week doing what you like best, which is not turning phone calls and scheduling and making appointments. It is spending a couple of extra hours that you save from that on seeing more clients and doing more clinical work, and of course finishing your well, no, I don't know, that's the best thing. Okay, your paperwork. So that's it. Matis, let's go back to residential for a moment. What precisely happens in a residential treatment? What is that?
So I mentioned to you that I work in 3 of the 5 levels of care. Actually, so those are actually 4, but I've worked in IOP, PHP, and I worked in residential as well as outpatient. So the residential, that's where I could probably speak most of it. Obviously, I have clients who've been in residential, but I like to speak about my experience. So I worked in a residential facility for children and adolescents, mostly adolescents, who were at that time what they would call them struggling with learning disabilities or on the MR spectrum, and they had co-occurring severe psychiatric disorders. And they couldn't be at home, these kids. Some of them were actually even offenders from the juvenile system. And they were really severely behavioral. So behavioral emotional struggles, as well as, impaired cognitively, some of them in significant ways. So there was actually a school on the campus. So they would go to school every day and they have teachers come. And then you have residential staff. Now, residential staff is really the support staff, and they have a certain amount depending on the needs of that client, but they're servicing that group of clients. And then they each have, like, sometimes it's in a building, sometimes it's in a cottage, sometimes it's some sort of house where a certain amount of the clients actually stayed, and they have a clinical staff, and then they have a residential staff monitor, and they help ensure that they're going to meals and going to programming and seeing the therapist. And then you have the clinical staff. So, and the clinical staff is really focusing on their treatment planning and their individual therapies, and perhaps doing some group therapies. So, and you're really, in this facility, this was for adolescents, they were really working very behaviorally on helping address and target, using a lot of, Pavlovian, concepts in terms of modifying
Conditioning
and modifying behavior. But they would often would go AWOL or would lose control, and they would need to be put in protective holes. So that was that they would break windows and try to hurt themselves. They would disrobe in front of everyone else. There would be a lot of extreme problematic behaviors, and they were coming from very, very complex environments. So that was that setting. But that's not, obviously that's for adolescents, and there are different programs. When you go to a residential eating disorder program, they're really focusing a lot on meal planning and ensuring that they're having meals and watching that they're eating the meals and feeding them, and at the same time doing some other emotional work.
And these are facilities where people stay for how long?
So I would say the average stay is probably 1 to 3 months where people would be in a residential facility. I would say that on average, the facility I was in was for adolescents, and many of them couldn't go back to their home. It was Department of Children and Families. By the way, the Department of Children and Families shut us down. That was before I left. So it's very complicated with a lot of the staff in that environment, and in terms of, I mean, it's a lot of medication, and there's a lot of, they're getting medication management, there's psychiatry, uh, there's evaluations, there's a lot of testing services that they're getting in this environment. So, that's what I would tell you about
Residential.
residential. Yeah.
Okay.
It's a way, the clients can get away from everything. And that's what I find. Even clients who go to a lower level of care, they come out, and many of them want to go back to residential because they have the ability to like shut everything out, especially adults, like family, responsibility. They just get taken care of. Everything. I mean, they have responsibilities there, and they're given tasks, and they have to focus on daily living, but they don't have all the stressors with
They're not responsible for other people, and they're not responsible for a colossal thing.
Yeah, but it's an important level of care, and it's necessary. They don't need necessarily the medical facility. They're not at that level. But a lot of times people are going to residential because they need to make significant changes on medication, or try other medication, or need more.
So they have to be in a controlled environment.
Correct. That's why people are struggling with substance abuse, for sure. Being in that very controlled environment is very important.
Okay.
Yeah. And then is the hospitalization. And I think the most important thing to really realize about hospitals, I don't know if you've ever seen a psych hospital, but that could be traumatic in itself if you have to go down. But hospitals don't really help people. They keep people safe. And that's really important. Like, don't get me wrong, it's super important. But there's not really much treatment. Actually, sometimes there is. So, for example, a very effective treatment we know is ECT. Now, you could do ECT outpatient. You can go a few times a week, but sometimes people need ECT on a daily basis, and they're getting that treatment while in hospitalization.
Tell the audience what ECT is for those who don't know.
Okay, that's electronic convulsive therapy, and that's where they maybe you remember from years ago, the idea of zapping your brain. But today, it's an incredibly effective treatment. They've come a very long way in doing it in a very, very safe, targeted, focused, and it can really, really help people who are struggling with severe depression, but even people with a catatonic or psychotic or high level mania. It is an effective treatment, and also many great programs have excellent psychiatric staff that can really also, they're monitoring them regularly, giving them medications aside from keeping them safe, and they can also address medical issues at the same time, which is a benefit of hospitalization. And then also that people need sometimes withdrawal from drugs and alcohol, or they need certain nutrition needs. They need this very restrictive environment, excuse me, to get to their goal. So that's inpatient and hospitalization as far as that level of care. So sometimes people come out of hospitalization, they'll go to PHP, and then they'll go to IOP, or come out of hospitalization, they'll go straight to IOP. People go to residential, then they'll go down to PHP or IOP. Sometimes people go to residential, they'll go straight to outpatient. Some people go to hospitalization, they'll go straight to outpatient. Even though they're recommended very often to go to IOP, PHP, they're not. They're just not going for a variety of reasons. So they're all connected. Did I give a good overview there? Was that clear, Maishi? Did you?
That's beautiful. Yeah, I think we got a sense of, kind of scanning through my client caseload over the years and who would have perhaps benefited. I think that hospitalization is pretty clear cut. It's really for safety purposes when somebody's not safe, and they need to be monitored 24/7, and they need medication management and treatment.
Yeah.
That would be hospitalization. Residential, I guess, becomes a little more iffy. Who belongs in residential treatment? And then IOP and PHP, sometimes a toss up. And I see somebody's asking, what's IPP?
IPP, I'm not familiar with
I'm not
IPP.
familiar with the term. Matis, what's a partial, I'm sorry, a halfway house? Who would that be appropriate for?
I think there was someone here in the audience who actually said they worked in a halfway house. Was that correct?
Yeah, was it ZC or was it Yankee? ZC, was it you? No?
That wasn't.
Or Yoel? Maybe it was Yoel. I think it was Yoel.
Was Yoel
Yeah,
still?
Yoel,
Yeah.
did you
Yeah.
actually work in a halfway house?
I worked in a halfway house as a chaplain
Okay. Can you tell us what it
before.
is, who it's for? Who is it targeting?
Yeah, it's a step down from a inpatient for addiction. And it's to help them make that transition back into, the real world, shall we say. Like Montes was saying, it's a risky time, and the statistics for relapse are significant. And it provides a supportive system. And the two that I saw were a little bit different, but they all had, like Montes said, therapy at least once a week. They had group. They had like optional group. There were external 12-step meetings that they could be taken to because they all had transportation. They had meals provided. They had a support system, including, me, as for the spiritual, and it was and they both had help. They helped the clients find jobs. So the goal was, to help them transition back into the world without, with enough support to minimize the chances of relapse and establish connection. We say the opposite of addiction is not sobriety, it's connection.
Hmm.
Yeah, and thank you for that. And I think the halfway house term, as far as I know, and you correct me wrong,
Mhm.
is mostly associated with the substance
Yes.
use and abuse world, such as sober living homes as well, which I believe are even less structured than halfway house. Sober living are where people are coming together and they don't have as much support in that environment. Like in the home, they're not necessarily having staff, but it's a group of people coming together that need an environment where they continue to transition into society, but they have one another to work on sobriety and to ensure that they're not addressing all those things that can lead to relapse. But I think those levels of care are specific for that.
And just to clarify, the term halfway house also is, I think, maybe even originally for people coming out of jail, out of institutions.
Okay.
And so that's a different story.
Mm-hmm.
Mhm. Okay. Does anybody else have any questions or comments on this? Has this been clear for you?
I
Do
think
you have a case question or go ahead? What's that?
Raised her hand, I believe. Is that correct?
Did you? Okay, go ahead.
Yeah, I have a question. Okay, so I'm going to try to spare the details, but still give some detail to explain the case. I want to know if that considers I should consider high level of care for that client. A client that presents with manic to a point that she goes on and on yelling and talking and isn't able to stop. And that was like a 45-minute session together with another family member in the session, whom she brought as a companion or as a support in the session. Very angry, has children, has a hard time with budgeting, to say the least. It's actually an addiction. And I'm concerned for her safety because I wasn't able to stop her and say, can you listen to me? And she wasn't able to. She was just going on and on.
It sounds like like you said, your client is struggling with bipolar disorder and perhaps in a hypomanic state, or maybe close to a manic state, and um, and your concerns are quite valid. And I'm so glad you brought up this case, because just to give you an example, like we had a young woman who just came for an intake, and she was coming out of hospitalization. She was on such intense medication that she wasn't even able, I didn't, based on my assessment, I didn't think she would be able to gain from the program where she was at that point. And I think if you're talking about someone who has pressured speech, hypomanic, level of impulsivity in terms of spending, and you put them, and they're not that stable, you put them in a IOP PHP environment in a group. I mean, we've had clients who are a little bit, on the continuum of somewhat hypomanic, but if they're going to just could be talking and maybe even borderline delusional, it's not going to be an effective place of treatment for them. And therefore, really, depending on her current presentation, first thing is stabilization with medication. Now, that doesn't mean hospitalization per se. So in other words, you want to do a pretty, robust risk assessment here to make sure that there's safety and that there's support in the environment. And then you really want to collaborate with the whoever's doing the pharmacotherapy, or a nurse practitioner, psychiatrist, to stabilize that individual medication. Now, once they stabilize, and we do see that a lot, and they need skills to be able to work through their struggles and their bipolar disorder, they might be very appropriate for an IOP environment. But the way she's presenting, you can't even get a word in edgewise in trying to do individual therapy. That would be really concerning. And I would immediately contact her prescriber. And if she's not currently with a prescriber, I would get her to a prescriber before she gets to a place where she might need hospitalization. So that's what I would say in a case like that.
Okay. Any other questions?
I saw some in the chat, Maishi. I don't know. Was there any in the chat, or?
There was just a question of the IPP.
Oh.
And
okay. Here's a question. What can the therapist do to help the client enter an IOP ready to join a trusting relationship, especially when they need it and yet are resistant to going to the IOP? It's a great question. What do you do with a client who's resistant? I mean, we're working with clients who need this level of care, but they're really resistant because of the shame, because of the other barriers, because of their schedule, because money. There are a lot of things that really get in the way of getting a person. And how do I get my client to go to this higher level of care? So I can tell you how we operate and what I would suggest for any program. Get them to just get in the door. It's the same thing with therapy. Like, if just go for a consultation, go for an intake. There's no commitment. Let them come in the door, let them meet us so we can start to build the trust with them that the programs could explain to them and address all their concerns. That's really huge. If you get them from your office to actually even enter into the facility, I think that's a big step. And that's going to really work on, that's really going to help increase their ability to trust. The fear of the unknown is huge. A lot of people are struggling with severe anxiety, vulnerability, emotional sensitivity, histories of significant trauma. It's scary. So I think if they can go into that environment, and that was one thing we did in our facility. I mean, we built, and if you could see some of the pictures, it's like a spa-like environment.
Beautiful.
It's beautiful. And that was the vision. I wanted people to just walk in the door and wow, just feel that common sense, like I'm a person. This is not a hospital, right? This is just a beautiful place where I can heal. And that was important. Someone actually just said an FYI, people are here who might be in my IOP now. That's I guess I don't think I disclosed any specifics of any information, but I think I would love, I guess in general, is again, I'm glad if they're here, and I also want to destigmatize the idea of going to a higher level of care, hopefully at some point. I know we're not there yet, and I'm not asking those people to mention their names, that's not my goal. But I think is, we don't have to, when we talk about IOP, we can talk about what it is and what the struggles are and that it's real and normalize it.
And I think they deserve accolades. Those who are willing to face whether it's the traumas or the challenges that uh, impede and disrupt their quality of life to such a degree, and are willing to go face it,
Yeah.
and not only go for weekly therapy, but to go into an IOP in which they are really, really investing in caring for themselves in a very, very on a very high level. They deserve our accolades.
Yeah, and I would tell you that the people that we see in IEP and PHP, they are, I hate to use the word regular, but you walk down the street, it's like you and me. It's like they didn't choose this. People are struggling with significant mental illness. It's not recognized, and the support and the help is limited. And obviously, we dedicate our lives to help these individuals. And it's just amazing. And I appreciate you saying that, Moshe. It's the people who are willing and throw themselves in this, although it's difficult because they want to help themselves, they want to help their family. Many of them, they really don't even want to be there, but there's a part of them that's like pushing them to just do this, or the support of others to do this. And it's amazing. It's amazing to see the change. I remember there was, after our first group left in the program, there was one young woman who walked in for an outpatient session. And I said to her, "You look great. How you doing?" And she looked at me and she says, "I don't want to kill myself anymore." And like, to me, that was like, that's what we're doing. That's the goal of this level of care. Yeah, they might still have so much more work to do. But if we can get them to a place that they can believe in themselves, feel a sense of empowerment, believe in a future, decrease this feeling of hopelessness and helplessness, and be able to focus on their strengths and really build their skills. And I think DBT is really important in these environments because it's so short term, and many of them are engaging in struggling with regulating their emotions, and therefore using unhelpful ways and means, that they need different skills to be able to be more mindful and present and aware, and be able to tolerate the stress and move towards places of acceptance and build positivity and structure in their lives, and some short-term skills when they're highly, highly distressed and in states of crisis, and support to help them do that. And it's pretty incredible what a level of care like this can do. Now, it's not magic, and not everyone's going to come in, and some people actually step down and step back up, or they need a different level of care, as I mentioned before. But I think it's really important to understand that when we're in this field, that there are, other, very important comprehensive level of cares that are needed for some of the clients we treat.
Great. So I just put a poll out there. I'm wondering how helpful this was for you. Do you think that after hearing this, you've been more educated, and this has been helpful in causing you to refer people to a higher level of care? And the three choices are yes, I will now be able to refer to a higher level of care. The second choice is I always did, and this was not necessarily informative, not because it wasn't a great presentation, it obviously is, but because I always knew about it and I always did. Or choice number three is this didn't convince me. I'll continue to treat people one-on-one. If they're struggling, maybe I'll add 1 or 2 sessions a week for them, but won't sum. So if you can respond to the poll, it's just something a little different that we're doing this week.
I'll finish my question. My computer froze and I got like thrown off.
Sure.
Go ahead.
Okay. So I think I'm clear with the fact that the client first needs to see a psychiatrist and then maybe enter a program, correct? Is that correct? Okay. What if a client refuses? Is it still safe for me to see a client in such a state?
It's a great question. It really has a lot to do with assessment, and unfortunately, especially people who are struggling with bipolar disorder, which is a whole talk in itself, many of them are very, very comfortable in the state they're in. You know, I remember years ago one supervisor said, if we could take mania and bottle it, you know, we'd be really rich and successful. It gives them that sense of, I can do anything, I'm capable, there's no self-consciousness, there's all this energy, don't have to sleep. So, and that's part of the struggle of bipolar disorder, as we know, that many people don't take the medications and follow up with treatment. So sometimes I want to answer the two. Obviously, as far as safety, you got to do an appropriate risk assessment. That's number one. But things that I've done in the past where someone refused treatment, let's say I was working with an individual and I felt that they needed a higher level of care. They needed to go a higher level of care for an eating disorder. And they didn't want to do that. And I knew they had a relationship with me and they valued the therapy. And I said, well, this is not the appropriate level of care for you. So I'm going to have to stop until you go to a higher level of care and come back. But it's irresponsible for me. And in a way, I might even be reinforcing their behavior because I'm sort of allowing them to continue this process in this outpatient therapy, which is not where they belong. And they were not happy with me, but they did end up going to a higher level of care in that case. But even if they didn't, for me to continue treating when it's not the appropriate level of care, and I think we didn't talk about too much, but I see that. I see that there are therapists who are treating individuals in outpatient therapy when it's not the appropriate level of care.
That's right. And I think that's what makes this talk tonight so appropriate. Really to learn what the other options are and to really just reflect, right, on our caseload and past caseloads and say, are we treating everybody adequately? Or are there people who need more than us, but they're coming because they just want help? So
Yeah.
I see there's 11 votes, and 55% of people are saying that they will now be able to refer to a higher level of care, and 45% are actually saying that they always did. So that's a nice number of people who were aware of this and referred or felt that they would refer. So that's great.
Yeah. Maishi, if I can actually, if it's okay with you, share a little bit about our program.
Sure, you already have, but go ahead.
Yeah, it's just a little bit more specific. And you asked me how I got to this, and I'll tell you because just for the population that we, we opened about 5 months ago. I was working on this for over 3 years until I got this off the ground. And to get it's a process, as you can imagine. So I actually met. I was out of town, and I was at a bar mitzvah, and there's someone who lives in community in LA, and they actually own a couple